Finals SAQ11 Acute Cardiac Tamponade. The case: you are asked to review a 65-year-old man on the cardiac intensive care unit who underwent coronary artery bypass surgery earlier in the day. A. Which clinical signs suggest the development of acute cardiac tamponade? Clinical signs include Beck's triad, which includes hypotension, raised JVP, and muffled heart sounds. The patient may be in shock with hypotension, tachycardia, clammy cool peripheries, reduced capillary refill, reduced cerebration, cardiac arrest, resistant to fluids and inotropes. There may be pericardial rub, pulsus paradoxus, which is abnormally large decrease in systolic pressure during inspiration. During spontaneous inspiration, the full right heart encroaches on the left and blood pools in the pulmonary vasculature, both of which reduces left heart filling and thus systolic pressure. In cardiac tamponade, the effect is exacerbated and the difference in pressure between the right and left heart is lost. Positive pressure ventilation results in a reversal of timings. Kussmaul sign, which is rise or lack of fall of JVP with inspiration. This is due to failure of the constricted right heart to accommodate increased venous return that occurs with reduced intrathoracic pressure that accompanies spontaneous inspiration. B. List the investigations and their associated derangements that could confirm the diagnosis of acute cardiac tamponade. Transesophageal or transthoracic echo shows pericardial separation of more than 1 cm. Pericardial collections may be atypical in appearance following cardiac surgery, yet still cause significant hemodynamic compromise. Sequentially, with worsening cardiac tamponade, the right atrial free wall collapses in systole, followed by right ventricular free wall collapse in diastole, followed by left atrial free wall collapse in systole. There is exaggerated respiratory variation in trans-tricuspid flow and trans-mitral flow. Left shift of interventricular septum may be seen, with IVC dilatation without respiratory variation in size and swinging heart. Chest radiograph shows enlarged cardiac silhouette, which is flask-shaped. ECG shows small complexes with electrical alternance, which refers to varying waveform size due to movement of the heart within the pericardial sac from beat to beat. Other investigations such as ultrasound-guided pericardiocentesis, cardiac catheter studies, and CT scans are unlikely to be useful given the time frame of acute cardiac tamponade. C. What is the management of acute cardiac tamponade in this patient? Cardiac tamponade following cardiac surgery is likely to be due to failed hemostasis. It is rapidly progressive with increased risk of cardiac arrest and mortality. Plan for decompressive sternotomy on the intensive care unit. No time is permitted for transfer to the operating theatre. Opening the sternum usually reverses the life-threatening hemodynamic compromise. Follow an ABC approach, assessing and managing the patient simultaneously. Fast bleed team and call for re-sternotomy trolley. The surgical team should be ready before induction. Anesthetic and operating department practitioner support should be requested, but may need to proceed without their assistance if the patient is rapidly deteriorating. Contact the perfusionist, as the patient may need to go back on bypass. Activate major hemorrhage protocol. Airway. Provide 100% oxygen to increase cardiac oxygen supply. Breathing. Intubate the patient if not already intubated. Provide positive pressure ventilation. However, positive airway pressure has deleterious effects on cardiac filling. PEEP and high airway pressures should be avoided as much as possible. Do not induce until the surgeons are poised, ready to go. Maintain oxygenation with minimal ventilation. C. Circulation. Ensure large bore IV access available. Increase intravascular filling to maximize effective venous return. Provide vasopressor if necessary. Major hemorrhage protocol should be activated. However, tamponade is not always associated with large blood loss. Neurology. If the patient is sufficiently stable for induction drugs to be used, consider the use of opioids, ketamine, and benzodiazepines. Avoid causing myocardial depression. If the patient is in peri-arrest, it may be inappropriate to use any induction drugs, which typically causes myocardial depression. Hematology. Coagulopathy may be present due to recent bypass surgery or developed due to blood loss. Hemoglobin and coagulation should be monitored with near-patient testing. Blood administration, reversal of heparin, and administration of other clotting products as indicated. Alternatively, management of anticoagulation to go back on bypass may be needed.